Every individual from the top to the bottom of this organization was instrumental in the success in taking care of the patients. I've never seen such team spirit and team working in an organization as I have with the Brompton and Harefield. Everybody dropped what they needed to do and put patients first.
In the beginning, things were changing by the hour and it was quite tough. We were all worried that will we get COVID, we were worried that will our family members, we haven't seen our family in months now. We all worked as a team, we were a strong team and we were there for each other in this difficult time.
Many of the patients who were arriving in the hospital were already sedated and intubated, and their families had not been able to accompany them. So families didn't necessarily know where their loved ones were, they didn't know who was looking after them, they didn't know how sick they were and anything about their progress. So it was recognised very early that we needed to set up some sort of system for updating families.
Before the COVID crisis really hit, the Trust decided that it would need to do staff testing. We had to make a plan, work out how we were going to do it. We had to look at the environment, the equipment we would need.
The virus gets into the lung and it causes a lot of inflammation. So the lung is essentially full of inflammatory cells and therefore it's hard to breathe. So to cope with that, the patient has to try to breathe harder and faster to get enough oxygen into their body. That gives them a sensation of breathlessness. And when it's sufficiently severe, of course, the patient has to be put onto, if you like, a big breathing machine, an intensive care unit ventilator, and treated in the intensive care. But the principle of the treatment is that you're hoping that the virus will get better and burn itself out, because the patient will then get back to normal. Now that can be very mild. We know that some people are even asymptomatic, they don't even know they've had the virus, and at the other extreme we see people who require 3 or 4 weeks of very high-tech serious intensive care treatment.
Once a person is infected with COVID, there are other organisms that are associated with it. So there are other fungal and bacterial work that is going on to support the patients. Unlike bacteria, where you can actually culture it and grow it and you can actually see, smell and actually feel, viruses are invisible to our naked eye. There is always a sense of insecurity, there is the unknown factor. However, we are used to handling hazard group 3 organisms.
When all other measures fail, i.e. patients have been placed on a ventilator, they've been given antibiotics, they've been placed on their front to try and improve the amount of oxygen that is getting into the bloodstream, they've been given drugs to try and get rid of plasma that leaks into the air spaces, and if all of that doesn't work and the ventilator itself has the potential to cause more injury because of the high pressures and the volumes that the ventilator or the bellows is delivering into the lungs, then we would often be called to try and discuss whether these patients would be placed onto ECMO, or extracorporeal membrane oxygenation, which effectively involves us putting 2 large cannulae into the veins, taking blood out, oxygenating it, putting it back, and then really reducing the pressures that the bellows and the ventilator is inducing. And that is something that we've really seen quite significantly within COVID.
So this is one of the devices that we're currently testing with the COVID-19 population. It's called a beacon, and what it does is it collects information from the patients. We add a SATS probe onto the patient so we know what their saturations are, and we also insert this tubing into the patient's breathing system so we can get breath by breath analysis of the patients. We get readings to do with oxygen, carbon dioxide, even how much energy they're expending. And it uses that information to run through what it thinks is the best form of ventilation for these patients, and will generate advice based on that.
As difficult as the time it was, COVID's actually brought a lot of good things to the unit that we'll probably keep forever. So the ability to use Microsoft Teams and provide webcam calls to families to keep in contact with their loved ones. The use of our family liaison team, who were instrumental in making those phone calls every day to those poor families who were at home, estranged from their loved one and not able to make it into the hospital. As a multidisciplinary team, COVID has really brought everybody together.
Heal might come today. The healer might come and take away the pain. The healer might bring the rain. The healer might leave you in a hurricane. Oh, but keep breathing on the pounding wave.
When the going got tough, and it really did get tough with PPE at one point, we became very creative with the staff. Our clinical engineering team made visors when we couldn't get them, so they've made at least 10,000 face shields. They designed a mock-up of a gown. That gown is now being processed and made by a group of professional designers and volunteers, and they've made at least 30,000 gowns for us.
We were asked to kind of coordinate on a project on converting theatre drapes into gowns for frontline staff. The initial message came out asking us to see if we could set it up to convert 1,000 a day. We had a very kind offer from the Kensington and Chelsea College. They got in contact saying we would be able to use this space. The designer very kindly put out a message looking for volunteers, and we've had an amazing response.
They sent me some photos of somebody standing there with a theatre drape like that, and then we kind of created a pattern based on some gowns that they sent. It gave me a real sense of purpose, and I think that's probably quite similar for most people who are here.
To supply a hospital, which is locally, directly, there's nothing more actually exciting than that.
My hope is that I'm giving the medical team gowns that they can feel protected in.
Under the current climate, the patients appreciate the reasons behind it, and actually, they're looking to see that we're doing things properly. So they're looking to see that we have the masks on. They're looking to see that we have the visors on. They're looking to see, if we're washing our hands between doing certain tasks and procedures. They're looking to see how we're engaging with one another. Yes, it is difficult in terms of communication and being able to express yourself facially, but I think the clients understand the need for it.
I think we've all been really frustrated in not being able to get the patients to see our faces and to see who they're speaking to. And so that compassion has been limited because they're frightened, they're confused, and you can't do very much about that if they can't hear you because you're talking through a mask and a visor, and you can't give as much compassion and care and love that you want to because you're all in your PPE.
We get really thirsty with a mask, and communicating with each other makes a little bit harder because with a mask and a visor and everything, people find it a bit harder to hear.
We've had to train people in matters of hours and few days to undertake roles which we would have possibly used weeks, if not months, to do in the past. And that's great, someone who's been working in an outpatient department for years, diligently and carefully, suddenly having to find themselves repurposed working in an ITU ward.
Our roles have completely changed. For me, our main role is supporting all the staff who now are looking after ventilated patients, filter patients, trying to learn the ventilator, which is currently what we're trying to do at the moment. It's just a huge, huge learning curve for all of us. Obviously, we're in unknown territory here. It's completely something we've never done or the whole country's never dealt with.
We've had to send staff on a regular basis to help out in ITU. This is where all the intubated and ventilated patients are being cared for, all the COVID patients, which has been quite daunting for us. We've had a lot of training and there are a lot of resources available. I have to say we've had a lot of support from the ITU nurses and the sisters in ITU as well.
I've been amazed at how many of the nurses, the doctors have all stepped up to learn new skills. It's been absolutely amazing and quite humbling really. And one of the ones was with paediatric intensive care where the whole team has switched from tiny little things like this, babies, to huge great big adults, and they've not been really fazed by it.
These nurses and HCAs have all had to learn and upskill completely. But they've learned all these new skills and they've been really good at it and they've done it really quickly, and actually it's a really good idea to keep these skills, keep them using these skills.
The whole experience, I think, has been very humbling for everybody. It has been scary because I think for a few minutes of every day, I've thought that might be me, I might get that, I might not survive, which, you know, is not nice. You sort of forget about it after a few seconds because that's the best thing to do. But I think there'll be some real positives out of it. As I say, people stepping out of their comfort zone, doing something that they've never had to do before, they've never been asked to do before, but realising that they can. And I think it will improve what we do.
All the different departments have been able to sort of come together. We've been able to work with people that we've never worked with before. I've worked with new nurses that I've never seen. So it's just the fact that it's been such a group effort and we're all trying our best to take care of each other. Even though it was a difficult time, we were able to actually fight through it and come out of it together.
The wife of one patient I spoke to said that she and her husband used to sing together, and the nursing staff were able to facilitate her singing to her husband while he was on critical care. Over time, we've learnt that it's very important to ask families to tell us about their loved one, so we can build a picture of this individual, so that when they improved and were sort of moving through the pathway, we were able to ensure that we called them by their preferred name, speak to them in an appropriate language if necessary, and talk to them about their work and their hobbies and their family in the normal way that you would interact with patients.
One of our patients who was very, very confused, he thought his son had died. We were able to get the son on the video link, and it changed his whole outlook and changed his whole being, that he suddenly realised that he was confused and it wasn't real, but his son was still alive. That was amazing.
It's been a journey for me. Rough one. One night I had a bad experience. All kind of nightmare. It was scary. I dreamt my son died. I said, no, let him live and let me die. I did not sleep for the whole night. Following night, they sent me a nurse. I said, you're like my mom. She said, I'm not old enough to be your mom. I said, no, it's the touch. Very caring. So every step of the way, I felt I was getting stronger. I began to feel the change gradual. And I began to use my legs and my hands. And in the past 2 weeks, I hear folks start talking about home. And when I hear home, it was like another infusion of energy. Those folks who touch me, they really touch my life. I'm going home. I'm so glad I'm going home.
It does give us hope. It gives us hope. You know, we want people to recover. We want people to get back their life. We want people to make it home to their families. Whatever we can do, we will work hardest to do it. I think when this eventually is over, it is going to feel very strange getting back to what was considered to be normal at that time. And I think the biggest consideration that I have to take at the time is the fact that this could happen again. This could happen again. So if there's any lessons to be learned, if there's anything to look back on retrospectively, is how did we deal with this? And how could we improve on care provision, and how could we prevent the spread of any future virus?
This sort of crisis has brought out the best in many of the people within the Trust, whether it be the way the process is run, whether it be the way we improve our care, non-intensive care specialists working within intensive care, specialists working with completely different, in different roles. It's actually very humbling.